The anterior cervical fusion, I think there are 4 important steps. We all need to remember that. So decompression, then I will quickly go what type of decompressions. Then the second aim of doing the surgery is to provide stability. And the third aim is to preserve the lordosis. And the fourth aim is to preserve the anatomical disc space to restore the foraminal height. So when you're doing this operation, all these 4 aims should be in your mind. So that's the main message. And so I'll talk stepwise. So apart from the steps, you also need to know what you're putting in and why you're putting in. In terms, you need to know a little bit about the grafts. You need to know a little bit about the cages, and you need to know a little bit about the plating systems. So in terms of decompression, the aim is adequate decompression. And the decompression depends upon the underlying pathology. So you have to do central decompression, you have to do lateral decompression, and depending on the pathology, the decompression could consist of just ACDF, multiple ACDFs, or vertebrectomies. So can any of the trainee tell me type of bone grafts we use? Any trainee? I think otherwise we'll keep sitting and everything will be going on top of our head. Stand up, please. Just give me one name. Sorry? Right, bone grafts. So what are the type of bone grafts? Yeah, there are types. Okay, so you need to know that's the type of bone graft we're using. The allograft, what is allograft? Same species. And what is the autograft? And then there are bone substitutes. So this is the problem with the allograft. We all know that you need to process the bone, sterilize techniques. It varies from person to person, different type of the source of the bone. Then there is a problem with the bone structure quality, and then antigenicity. I think almost all of us have stopped using the allografts. I don't know, anybody in the hall is still using the allograft? So I'll show you what you're using. So bone substitutes. I know what he's talking, yeah? So what type of bone substitutes we have? So osteogenic graft, osteoinductive, osteoconductive, and osteopromotive graft. So now we using completely different process type of the allograft, what he's talking. So what we were using, the cow and the pig bone before 2000, I've stopped using all of those. So this is the second and third generation of the allografts which we're using, but you will be asked in the exam. What is osteoinductive? What are the osteoinductive is in front of you? Yeah, which induces the bone. What is osteoconductive? It induces the bone formation by acting on the cells that form the bone. And the osteoconductive function as a scaffold. And then there's a fourth variety, which is osteopromotive. So what message I want to give is, whatever you're using it, you need to know what you're using and why you're using it and what's the difference between them. And then is the autograft. And the commonest place for the ACDF we use is the iliac bone crest. But remember, it will not induce the bone in soft tissue, therefore not clearly osteoinductive. The importance of that is, if you don't prepare the disc space properly, if you don't remove the end plate, which part of the end plate? Cartilaginous. The fusion is.
You have 5 minutes left in case for this case, why you use ACDF rather than arthroplasty or foraminal.
Oh dear. So this is for the graft. It's the cage and the ideal criteria for the cage. You need to know that. So I'll just quickly skip that. These are the cage materials we use. What type of cages we use? Just that's are the actually materials. And what are the type of cages? That's the material we're using. What are the types? No, I'm not.
You're supposed to be making an argument, telling these people why you should do ACDF.
Okay, I'll just finish there. So I wanted to convey you this message. So the reason I do the ACDF is, which I put on my very first slide, I can use it in a kyphotic postures. I can use it patient who have associated instability. I can use it to restore the sagittal balance. I can use it to restore the stability, and I can use it to do the adequate decompression if I need to go quite far laterally, which I can't use if I'm doing the implant. So if I just go to the last one, in that case, and we can discuss. So there are threaded cages and there are impacted cages. These are the type of the cages. And these are the classification of the plates. I wanted to convey to you whatever you're using, you need to know what you're using. You should know what type of cages, and when you need to put the plate on, you need to know that. So I'll go to the last slide, and I stored, this is the, okay. I'll have to skip that. So I think I got the wrong message that I'm gonna talk a little bit about the fusion. So, as I said, there are indications, the patients where I use the ACDF, in my opinion, the disc replacement is an expensive ACDF. If you read the literature, about 1/3 fuse. You can't use them in the kyphotic posture. You can't use in a patient which have associated instability. And you can't use in a patient where you need the quite extensive decompression. Right, any questions? So this is the, I just go back. I want to give you one quick message. So if you're taking the graft from the hip bone, that's the argument I will get is that you can have the morbidity from the donor side. To counteract that, we came up with this small technique where while you're drilling, you can trap the bone dust. You don't have to use the allograft at all. And then you can collect this dust. This is a small device I designed, and then this is available on the paper in the spine paper. So this avoids any donor side complications. You can take and filter this bone dust. You can fill it with the bone graft and into the cages, and it's as strong as the graft you take from the iliac bone graft. So the disadvantage of you doing ACDF was if you're taking the graft from the iliac crest, you have at least 1/3 people have a morbidity from the iliac crest. So we also have managed to circumvent that problem. And if I just show you we now have done about 450 cases with this technique, and the results are comparable with the iliac bone graft.
Actually use iliac crest instead of this cages. To avoid the cages, you use this.
No, if the cages.
Otherwise, you are getting from vertebra ossified and little bit drilling or thing.
So you need something to give you this, restore the femoral height and the setup. If you use a bone graft at its own, as the previous studies are, the bone graft will collapse in about 30 to 50% of the patients, the graft will subside, and you'll still end up having the femoral narrowing. So you have to use a scaffolding to take the bone dust into it.
In the interest of time, we're going to move on and do questions after the three presentations have been done. So we're going to ask Harrison Kim